This is Dr. John Odette. In this case, I'll be describing a case of a AMO Tecnis Toric lens that has rotated in the postoperative period. You can see this lens has rotated by about 20 degrees. It is a ZCT 400, so 20 degrees has made the patient outcome quite undesirable. Her uncorrected vision is about 2080 to 2100 at this time. You can see I use a Donnenfeld flap applanator to open the primary wound that was made at the time of the surgery. This is about 4 weeks post-operative period. I then use a chain cannula on my viscoelastic and inject viscoelastic behind the toric lens. I also like to free up the haptics. This lens was pretty loose because it was in the early postoperative period, and there was very good cortical cleanup done at the time of the initial surgery. You can see I free up the first haptic, and then I use the chain cannula to free up the second haptic. Once again, this is a very good method, a very good instrument to use in doing IOL exchanges, rotations, things of this nature, because you can inject viscoelastic behind the lens. I then use the same chain cannula to go under the lens and retrieve the trailing haptic. I will pull this haptic out of the primary incision. So now the lens the optic is still inside the eye, and the haptic, trailing haptic is out of the primary wound. Here I'm using a Morcher CTR, or capsular tension ring, injecting it under the IOL, and once again leaving the trailing islet out of the eye. I will use a cow hitch technique and pass some 10-0 nylon suture through the islet of the CTR, and as I mentioned, I use a cow hitch technique around the islet. The next step is to suture this islet to the haptic of the Tecnis Toric lens. In the past I had gone the most distal point. Now I go about 1 to 2 millimeters proximal to the most distal aspect of the haptic. This allows for better centration of the lens. You can see I'm passing this 9-0 nylon directly through the acrylic haptic. I will then suture the haptic to the islet of the CTR. Another modification I have made on this technique at this point is to leave the suture ends long in the initial period here. You'll see this, I'm just tightening down the knot. I do like to have the knot medially located, so when I am rotating the lens inside the bag, the knot is not rubbing on the equator of the capsule. You can see I'm just doing a simple square knot here. It is in the medial aspect. It is slightly out of focus. I apologize for that. And just tightening down this knot. Now, in the past, as I mentioned, I would cut these ends short and rotate in the bag. At this point, I've actually left them completely long, and I'm rotating the CTR and the lens into the bag. You can see the eyelid of the CTR is still attached to the haptic there. Passes nicely into the bag. I'm using just a simple collar button to rotate it into position. You can see the ends of the suture are pretty long at this point. I did this to not create little barbs from the suture that may drag on the capsule when rotating the lens inside the bag. So they're cut long, still out of the primary wound. Next, I will go in with my collar button again and rotate the lens into the desired position. Rotation, even when it is sutured to the CTR, is possible. It doesn't rotate nearly as freely as it otherwise would, but as you can see here, it doesn't require that much effort to rotate the lens CTR complex. Now I'm going in and using a simple MST micro scissors to cut the long ends of the suture. I initially tried tucking these long, but I found that the long ends would sometimes extrude, so I cut them somewhat short and placed them into the equator of the bag. I then go in with my IA. This is a silicone IA tip made by Alcon, and you can see I have my IA power very high. That lens is stable. It is not moving, it is not rotating whatsoever. It is currently in the desired position. You can see my preoperative marking there with the gentian violet pen. I'm going behind the lens with the IA tip to remove any viscoelastic that's behind the lens and then repositioning it. You can see one of my sutures is still kind of long, and as I did not desire this to be out of the bag as it could possibly rub on the iris, I went back in and cut it just a little bit shorter and remove it with the micro forceps. I go back in and remove the remaining viscoelastic, and this case is complete. This patient, as I mentioned, was about 2100 uncorrected preoperatively. After this simple rotation, the patient was 20/20 on post-op day 1 and remained that way 3 months out. Thank you.